So I'm talking about orbital inflammatory disease, also known as non-specific or idiopathic orbital inflammation, or NSOI or NSOID, or orbital inflammatory disease. The first question is, what is this? So it's not a condition, it is an open-ended non-diagnosis where we actually do not know the cause for the inflammation. It is, and as we know, inflammation is never a diagnosis. Inflammation is the tissue response, and treatment of this inflammation cannot help us make a diagnosis. So in many cases, the response to steroids is not a diagnostic criteria for us to say that yes, this was NSOID because it responded to steroids. There can be many conditions that present as orbital inflammation, and many of which have systemic causes that lead to the inflammatory changes. And therefore, we must hunt and look for a cause before we label it as non-specific orbital inflammatory disease. So what all does it include? As we know, in the orbit, each of the structures that are there, which is the lacrimal gland, the extraocular muscles, the orbital nerve sheath, the fat, the apical tissues, and also the periscleral tissue, which is essentially a subset of the optic nerve, the optic neuritis that we see. Remember, none of these structures are, or inflammation of any of these structures are mutually exclusive. You can always have spillover inflammation from one structure to the other. So, clinical presentation, we grossly divided into three silos. So, one is dacryoadenitis, which is involving the lacrimal gland, myositis, which involves the extraocular muscles, and then very often, as we said, spillover is seen, includes every structure of the orbit, which is diffuse orbital inflammation. So when it is dacryoadenitis, this is typically unilateral or bilateral. In many cases, it can present with pain, as well as in some cases it can be painless. It is acute to subacute. You never see a extremely chronic inflammation that lasts months. And typically you see an S-shaped lesion, and also on palpation, and many times you will be able to palpate and feel a lacrimal gland. So a lacrimal gland enlargement which is palpable in the presence of inflammation helps you differentiate between whether it's a tumor or whether it's an inflammatory change. The next is myositis. As you can see, this is a far more angry looking eye than the previous patient. This is typically unilateral and is associated with pain, and not just pain along with movement. And as pain with movement and inflammatory changes causes restriction of movement, the patients often have diplopia. Congestion and chemosis are common along with the myositis. And as you can see in this patient, she is presenting with severe chemosis, and the extraocular muscles are enlarged. And on imaging, you can see diffuse inflammatory changes all around. Remember, the horizontal recti are more commonly involved than the vertical recti, and bone is almost always normal. There are no bony changes. At the same time, given that it is acute to subacute, thyroid orbital disease and metastasis need to be in your differential diagnosis before you confirm a diagnosis of sorts. And third, of course, is a diffuse orbital inflammation that involves almost every structure, the lacrimal gland, the extraocular muscles. These are very, very difficult to treat because they are unilateral and they keep repeating and often have suboptimal response to medication and treatment. Proptosis, ophthalmoplegia, and of course vision reduction is also there, given that the optic nerve is involved. Again, your differential should include thyroid eye disease, cellulitis, and CCF. So what investigations would you end up doing? The first thing is to image. Now, if you were to image, we have two options, which is CT and MRI. Now, say for example, this is a patient who came with orbital inflammation. You can see and clearly identify the recti and the lacrimal gland, the lateral rectus and the lacrimal gland being involved and inflamed. Now, if you see in this T1 image, you can see that the superior oblique and the superior rectus are involved. But on inversion recovery sequences, you can see that the oblique is no longer visible because that is indicative of an old inflammatory change. Current episode of inflammation is in the superior rectus, which then also on the sagittal slice is visible more clearly. This is a diffuse, this is how a diffuse inflammatory change would look in the intraconal space. You get hazy shadows, and the same patient on an axial slice, you can see the perineuritis is also present. The same patient here, you can see how the contrast enhancement lights up the optic nerve sheath. In this patient, we also ended up getting a T sign positive on ultrasound. Now this is diffuse orbital inflammation, where definitely a biopsy would be warranted, because this is the kind of case which you would suspect it to be also sitting on the fence of the lymphoma spectrum. Again, this was a change. Now you can see here that there are some bony changes also. This is a long-standing sclerotic variant of a non-specific orbital inflammatory disease. Now in some cases, there is also an overlap with scleritis, and as you would expect, the treatment remains essentially the same, because a CT scan didn't pick it up, but on an MRI you could see that there was a bullous retinal detachment along with choroidal inflammation. So what do you, when to investigate and what do you do? The specific it's typically not advisable to do the entire battery of all autoimmune diseases at the first visit. So if there is a mild disease, the first treatment trial would be to give non-steroidal anti-inflammatory drugs and to see for a response. If there is a classical disease where you expect pain on movement, diplopia, proptosis, then you definitely need to do your lab investigations and start the patient on oral corticosteroids with a controlled taper. If there is atypical disease where the pain does not fit in with the symptoms and signs that you see, and the onset is extremely acute, in addition to your basic workup, and of course an atypical disease is also when your normal response to steroids is suboptimal. At this point, you would consider a biopsy, or you would a definitive biopsy, or a steroid sparing agent in consultation with your physician. So like we said, a trial of steroids is usually given, but remember, a response to that is not confirmatory, because if the patient comes back to you with steroids, at that point you must think of whether you need to do a biopsy or not. And also, like I said, typical versus atypical, I will come back to that later. So the classic presentation we should keep in mind, which is periorbital pain with edema, erythema, proptosis, chemosis, and possibly vision loss. So if this is what you typically see, you must consider this to be the classical presentation of orbital inflammatory disease. And in this case, like we said, the first trial of treatment after imaging is systemic corticosteroids. If you get a good response, then you gradually taper it. If the response is good but the patient is unable to tolerate it, then you must consider even intraorbital. We often give Kenacort or triamcinolone injections or into the orbit, such that the patient has some relief from the local depot steroid there, which doesn't cause the systemic side effects. Also, if some symptoms are poorly tolerated, we can start immunosuppressants in these patients, which are non-steroidal or steroid sparing. However, if poor response is seen, at that point you must consider a biopsy to get a specific diagnosis, whether it is vaginous related, whether you have any other vasculitic cause that is causing the disease. And finally, also you need to rule out tumors, because tumors will give a poor response to steroids. Now, when you get atypical steroids, and at that time you have to do a biopsy. So this is basically the third line that we saw there. And here, if you are still able to get a diagnosis of NSOID, then along with your rheumatologist, you must start the treatment. Now here I want to talk a little bit about this patient whom we had seen for a long time. Now she kept presenting with the classical symptoms. You can see there's proptosis, chemosis, a mid-dilated pupil because there was a loss of vision. And you can see the bony changes was from a prior biopsy that she had undergone. And again, extraocular muscles which are extremely enlarged. We treated her with steroids. She didn't respond well. We did a biopsy, and the diagnosis was sclerosing NSOID, which means that there was intense sclerosis and a lot of hyaline changes. The proptosis remained. She kept coming back with episodes of inflammation. We would start the steroids, she would then respond, and the inflammation would settle down. So that is the before and the after. And at one point she was unable to tolerate the effects of steroids, so we had to shift her on azathioprine. Again she came up with severe loss of vision and extreme proptosis. We started again on additional concurrent steroids along with azathioprine. She responded very well. And finally, on maintenance of azathioprine, she was doing well. This was an MRI, and you can see the images, the extraocular muscles have settled down a lot. At that point now, of course, she got married and wanted to conceive and have a child, and they had to stop the azathioprine. So we stopped it, but again she landed up with further inflammation. And at that point, we decided to go ahead with orbital radiation. Low dose orbital radiation, 2200 centigrade was given, and at 6 months following radiation, this is her post radiation photo. There is absolutely no residual disease. The vision loss is slightly there because of the optic atrophy, but the proptosis, as you can see, has completely resolved, and she also had a baby girl after that. So radiation is also a treatment option, especially in refractory cases. So trial of steroids is given, but when you treat with steroids, do not under-treat. You have to give 1 mg per kg dosage. And biopsy when you have to, because remember, another lesion that also responds to steroids but keeps coming back, but in the absence of pain and inflammation, is lymphoma. And also adequately investigate when you have to. All autoimmune diseases should be investigated. IgG4 is one more thing. Always, it may be advisable if you have done a biopsy to also get an IgG4 immunohistochemistry. IgG4 diseases are a spectrum of diseases which are multisystemic in involvement, involves multiple systems, and also these patients have an increased risk of developing systemic lymphoma later on in life. Sclerosing variant was the patient that we spoke about, and in recalcitrant cases, radiation is an option. So this was one of the papers where we had actually gone back to all orbital biopsies done in the past 10 years and restained them with IgG4 to see what was the outcome. And we saw that 18 cases or 17% of the patients who were previously diagnosed as something else actually had IgG4 disease. So it tells you that almost maybe 1/5 of patients with other orbital pathologies were actually misdiagnosed when they actually had IgG4 related orbital disease. And it's important because systemically we need to tell them about the risk of lymphoma which is there. So I think with that we've covered fairly in detail orbital inflammatory disease. Do we have our next speaker, or Tarjani is supposed to come? So while she comes, if there are any questions, maybe we could answer.